Now going to move on to our next lecture. It gives me a lot of pleasure to introduce our next speaker, a friend of mine who I've known for a really long time, a partner in crime here at the University of Colorado, and really has taken our third space endoscopy program to another level. He heads our endoscopy, surgery, and tissue acquisition and apposition program, a professor of medicine. And Mihir is going to talk to us about post fellowship acquisition of new technology and skills. Mihir.
Thank you, everyone. And we've seen a lot of exciting new technology here during the course of the course so far. And so we get asked this question all the time as to there's so many new things happening in the world of endoscopy. How can I learn to do this? Either fellows ask this, or it's someone who's in practice outside of their fellowship because the procedure or the device did not exist at the time they were in training. So I'm going to talk about how and where we can acquire some of these skills in the next few minutes. So the agenda for my talk is we'll talk about new endoscopic technology and skills. We'll talk about avenues for acquisition of these skills, which of course leads to training, but more importantly, training and competency in these procedures, and what we are now calling as training to competency rather than just doing something. So let's get started. So when we think of new skills, we can think of the newest of the skills, and those are the ones in the lowest bullet that I have, which is the newer skills like bariatric endoscopy, POEM, ESD, interventional EUS, some of which you've been seeing during the course of the day. But there are folks who may want to learn the traditional interventional endoscopic skills, pancreatobiliary endoscopy like ERCP and US, and that may be a new skill that they may want to incorporate in their practice because maybe they didn't get enough training in these procedures during their standard training. The other question we get asked is, do I need to learn ERCP and EUS? I'm a general endoscopist and I would like to learn luminal advanced endoscopy such as stenting, EMR, and maybe even suturing. And so all of these to me is just learning a new skill. It doesn't necessarily have to be something novel that was just developed, in the last year or so. So in the interest of time for understanding the concept of acquiring these new skills, I'm going to focus on the newer skills because the concepts apply to all of these different procedures that may be new for someone who wants to learn them. So let's start with avenues for skill acquisition. By the way, this is on our Anschutz campus, and a bit of trivia. I don't know if you can read it, but it says that the average American walks 6,500 steps a day, and in Colorado, we are at 7,000 something. So yay, Colorado. So the time-tested method of training and learning is the master-apprentice or mentor-apprentice model. And you can't really go wrong. Yoda said it, so it is the way it's to be done. But I'm going to talk to you about some other ways that you can learn as well. So in Asia, the Japanese model for structured ESD training, I'm going to use ESD and POEM as an example throughout the course of this talk to kind of explain these concepts. So let's start with step one, which is accumulating basic knowledge and skills. And this is even before touching the scope, learning the diagnosis, indications, limitations, outcomes, and learning the devices. The next step is to observe experts in action and see how they handle the scope, see how they use different devices and so on. So that's, observing experts, then assisting them in performing the procedure. And in that mentor-apprentice model, this is relatively easy. You train with someone who's an expert, you assist them. That model may not be translatable, especially for some of these newer procedures, which are not easily available in places where you might be and you may not be able to train. After assisting experts, next step, work on simulator models, and these are ex vivo models like those that you saw yesterday, and then moving on to live animals and even some synthetic models, and then finally start performing these procedures again, under supervision is the key concept here. So in 2022, how can we translate that to the United States? So again, first step, obtain basic knowledge. And I would say, if you're looking at resection and ESD, just endoscopic assessment and examination. I can't emphasize this enough that it's not just okay to say there's a polyp in the ascending colon. That's not okay. There are a lot of things that go into it. And so assessing this with white light and narrowband imaging, then classifying this using the Paris and Kudo and NICE classification, that's everything before you even start thinking of resecting these lesions. Next step, observe cases performed by experts. And how do you get to do that? There's a lot of courses now being organized, many by the GI societies, many by medical institutions such as ours and others in this field, and even now being sponsored and hosted by our industry partners as well. So there's a lot of these courses out there that you can get education and even watch experts doing these cases. You can take it to the next level, which is in-person observation of live cases, which may be at your own institution or even doing little preceptorships that are available where you can go to a center where they do a lot of these, maybe spend a day or two and watch experts doing live cases. Hands-on training, I'm going to specifically talk about fellowships and mini fellowships, and I'll tell you what this means in just a bit. And finally, once you've gone through this whole process, then start independently doing human cases and initially start that with a proctor. So we proposed this in a recent paper where you first acquire cognitive and technical skills, then train under supervision, and then start performing these procedures independently. Take a look at the paper. It goes through a lot of what I'm about to share with you and a lot more details and references. So I'm going to use this upcoming course as an example of how to acquire newer skills, right? So we have this course coming in Vegas. We're going to talk about all these new procedures and do hands-on sessions. And there are many others, similar, some different, that teach different aspects of these newer tools, newer devices. And so you can go through, a lot of your emails you already get about these courses. They're on many GI Society websites. So attending courses will not train you to competency, but it'll give you that necessary initial step to understand the concepts and get to where you need to go. So moving on to these fellowships and mini fellowships. So a few centers in the US now have started offering 6-month or 12-month fellowships in these newer procedures. This could be an extension of fourth-year fellowship. Some of these are just extra fellowships. So you would not necessarily have to be a fourth-year fellow to continue, but you just do some extra training at whatever period you are in your career. Then there are mini fellowships, and we've offered these on a case-by-case basis as well. We typically don't advertise these, and many places may not advertise these mini fellowships. But if you approach these high-volume centers where these newer technology and newer techniques are being performed, they may be able to offer you smaller training periods. And this is a little tricky because most trainees who want to get into this field might already be beyond their training period in a busy practice and may not get to come for 3 months or 6 months at one time. So what we have offered is, based on the skill set that the trainee comes with, we can have them do short bursts of training, so they could come 1 or 2 weeks per month for a few months, taking time away from their practice and get to learn some of these techniques. So now let's move to training and competency. We just talked about, how or the avenues that you have to get to that training, but what does it mean to be trained in a procedure? So the traditional structure of GI fellowship or training has been this apprenticeship model where you learn on the job. And the ACGME sets these minimum standards that must be achieved in a 3-year GI fellowship program to graduate. And this includes a minimum number of procedures that fellows or trainees need to be signed off on to independently perform these procedures. And this numbers-based approach has become outdated. This is not the way to train anymore. This has led to a paradigm shift in medical training. And what this means is it's based on the concept that each trainee, or rather all trainees, don't progress and learn at the same pace. They go through a series of milestones and achievements which could happen at different times and at different case volumes. So because of this, just saying that you need to do 50 cases is not good enough anymore. So this has led to this concept of competency-based medical education. And this is where all training is moving, including these newer procedures. So the ASG suggests that we should move away from this numbers-based training and focus on measuring performance metrics and reach and achieve some of these competency thresholds. There are a lot of tools that have been described for evaluating training and trainee progress. You're familiar with the tools for EGD and colonoscopy, and Dr. Wani has developed one, which all of you know, for ERCP and EUS as well. So there's a lot of these training tools out there for assessing training and then training to competency. So there are major and minor skills as defined by the ASGE. A major skill is a new technique or procedure that involves a high level of complexity and involves maybe new technology, while the minor skill is just an extension or a little refinement of the established endoscopic procedures, which you may be already familiar with, and you just need to learn a few extra things, but not like a drastic new technology or technique that you need to acquire. And so examples of a major skill: ERCP, EUS, ESD, and POEM. And minor skills would be radiofrequency ablation, placement of intragastric balloons for weight loss, or maybe the over-the-scope clip. I should say that a minor skill, as defined here, doesn't mean it's a minor skill. It may be a major skill for someone who may not be familiar with doing Barrett's endoscopy, who may not be familiar with doing therapeutic endoscopy to the point of clipping and so on. So it could become a major skill. It's just whether it's an extension of what you know or just newly acquiring something. So let's look at some guidelines and curricula for ESD and POEM training. And this is just an example. So the European Society has a curriculum for high quality training in ESD. And what they emphasize is that trainees should not perform complex endoscopic procedures in humans independently without having undertaken sufficient training. The Japanese Society has a guideline for POEM, and they say that the initial skill acquisition should be through training on animal models. And again, here they do not provide a minimum number of procedures or minimum number of POEM cases that need to be done to obtain competency. And the reason for that is the data that we have right now for POEM training, as an example, is majority of it is animal training data or data from single center, single operator, and basically it's their own learning experience and their learning curve. And this may not apply to all trainees because these are experts who've been doing interventional endoscopy for many years, and then they acquired the POEM skill, and then they described their learning curve and said, well, it takes 50 cases for you to do something. That may not be true for someone else who may not start at that level of skill. And so again, there is no one set number that will get you to that competent level. So these are ASG training curricula. We published them recently. There's one for POEM, another one for ESD. And this outlines much of what I'm talking about, as in focusing on the different metrics for assessment and then getting there. It also talks about the different avenues that are available for training in these procedures. So let's look at a proposed training program, a training curriculum for ESD. This begins with, and in this case, first thing is defining the core skills in ESD. So the first step would be to deconstruct ESD into a bunch of steps, such as lesion characterization, marking the lesion, mucosal incision, submucosal dissection, maybe using traction, then hemostasis, elective closure, and then managing adverse events. Next would be to define quality metrics, such as what's the en-bloc resection rate, what's the complete or R0 resection rate, and so on. Once all of that is done, target is set for achieving competency such as 90% en-bloc resection rate, 75% curative resection, and a less than 3% perforation. And that's, if the trainee can achieve that, well, then now they've met those metrics for a training to competency. And then there's a tool that can be used. This is similar to a tool that's there for colonoscopy and EGD and ERCP and US, where each step of this procedure gets graded by the trainer as to whether the trainee can do this and how much help they need. We have a similar proposal for POEM, and this is our data from our site, where we deconstructed POEM into cognitive skills and technical skills. And in each of these categories, we have different steps there, and each of these steps is then graded by the trainer and we then look at when did the trainee achieve competence, and are they consistently able to do these steps on their own with minimal guidance. So that's typically how we propose this. Again, there's not much multi-center data to support this. There are some studies going on right now. So I think we will get there soon, but the point is that the training should be structured, there should be a curriculum, and the goal should be to get that training to get to a competency level, not just doing it. So I'm going to end with my take-home points here. GI endoscopy, as you know, has grown dramatically in the last decade. There's a lot of new procedures, new devices out there. There are multiple options currently available in the US for acquiring these skills, and there is no role for a just do it philosophy. Self-teaching without supervision is not acceptable today. Training to competency is crucial. There is a need to establish a standardized curriculum for skills, implement universally validated skill assessment tools, and ongoing evaluation. This is the last point, which is very important, that ongoing evaluation of these new skills is critical even after starting independent practice. So just because you've had the training and you've started doing this on your own doesn't mean that it's done. It means you still need to evaluate yourself and make sure that you're doing the right thing and achieving these metrics and outcomes that are desired. So with that, I will stop and take any questions. Thank you.
That was a fantastic presentation, Mihir. I wanted to know if any of the trainees in the audience have any questions. I know some questions were brought up during our Q&A session during the fellows course, but curious to know if you have any other questions. Would you consider afterwards to equal the extension or minus the matter of all of them
So, this comes up quite often, and I think exposure to esophageal POEM is one thing, and being competent is a different thing. So I think people sometimes say, and I've heard this from some of these mini fellowship trainees that I've had, where their home institution tells them that, oh, when you come back after training, we want you to start with GPOEM first because that's less risky. And I don't think there's any data to support that one is less risky, but I think what the institutions are thinking is that if there is an adverse outcome with a GPOEM, that's an endoscopic pyloromyotomy for gastroparesis, there are many general surgeons available for them to fix that problem if there's a perforation or a bleed. If there's an esophageal problem from an esophageal POEM, mediastinitis or something, that may require thoracic surgery, and some of these centers may not have thoracic surgery backup. So I think Those are logistical reasons for doing one versus the other. But I think that Z poems may be a shorter procedure because it's a short tunnel or no tunnel sometimes. But I wouldn't say you should start doing that because you've seen 10 esophageal poems, because I think it is very tricky to work in that tight space high up in the esophagus. And I think getting comfortable and competent in poem can then take you to the next step of doing some of these other locations. I don't think, if you've just been exposed, it would be a good idea. It would be better to complete the exposure to competency in that and then go to some of these other sites. Yes. So again, very important question. This, as in we don't have formalized credentialing guidelines. There are documents from societies that are out there which talk about it, but those are again opinions and they're not really backed by data. The way it happens in most places is when a trainee wants to learn this, they talk to their home institution, and when they get approval from them to yes, we support you in doing this, they would then take the next steps to acquire the training. When they come back, many of the institutions would do their due diligence. They would talk to the place that they got their training, make sure that they were okay, and they might even say, when you come back, you do 10 cases, and then we'll talk about those outcomes amongst a small group. Maybe it may be just in your division. It may not be like a with the hospital, but you just talk with your peers, and if everyone's happy with it, then you continue doing. So there's no set pathway, but that's typically how places would do it.
So Mihir, is it feasible for someone to get training in US ERCP and third space endoscopy during the traditional fourth year fellowship? What are your thoughts about that?
So again, I don't think one answer will fit everyone, but I think for most fourth year trainees, they're still trying to get competent in ERCP and US. And all of us know that these are difficult procedures to learn as well. So assuming it's the average fellow coming with an average skill set expected at that fourth year fellow level, they probably will not be able to learn everything, including third space, in 12 months. But if a fellow has had prior exposure to ERCP and US before starting their fourth year fellowship, they may have a faster learning curve for ERCP and US and might get exposure to the third space. But I don't know if they can get competent in all of them. But again, I don't think it applies as a blanket statement for everyone.
And can you also comment a little bit on interventional EUS? Do these principles apply to that as well? I've seen some literature suggesting that you should wait for at least 2 years, not literature as in science, but expert opinion that you should wait for 2 years, 3 years, 5 years before you start doing some of the interventional EUS procedures.
Right. So I think the concept here, I don't agree with saying 2 years or 5 years as a finite period of time. I think what these experts are probably saying is that you need to be really good at, interventional procedures as a whole before you can take on some of the higher risk ones. And, when you see some of these videos placing these transluminal stents and doing, EUS guided stents here and there, you see all these edited versions that look so nice. But when things go wrong, they go really wrong, and these are major disasters that you have had and the experience you've had, major crises that you might get. I don't think it's a finite period you need to do this. You just need to have enough experience before doing some of these tricky ones. And I think if you think you're there and you're ready to take it on, like all of us, have a senior person with you for the first few cases and do it together. And then you'll know very soon where you stand and how much help you need.
Copy. I can read questions.
I'm sorry, I didn't hear some of your question.
Hazardous case system.
So you mean before you start getting that extra training, right? So I think the first step, as I said, is education, right? Meaning learning about the technique. Nowadays, there's so many videos and papers that you can read, and the videos are all free out there, so you can, really get familiar with all of that. Then maybe, get some animal model experience, and that can be done at home as well. Many times you can get industry support to do that, and your industry folks can help you do some animal explant models and do that training. And once you're there, then you can think about, getting formal training. Many times there has been that what's not required, but many people consider that as a requirement to take that trip to Asia, to Japan, and observe experts and maybe do some work there and then come back. Now, that's not feasible for many people to just go to Asia and get that done. And I don't even know if in 2022, we have a lot of centers in the US that are now doing high volume of these newer procedures. So you may be able to just approach some folks and get to watch them. So I think just doing the basic homework first and then getting the training will also make you more attractive for that place to actually.
So much. Let's continue this conversation. I think the message is loud and clear. We need to move away from an apprenticeship based model. We need to move away from this concept of using case numbers or thresholds for competency. So, with that, I'm going to now move to room 16. Dr. Hamad, if we can have the case presentation, please.